Good morning. On behalf of Hyponatremia, I would like to welcome you all for today's session. Good evening to those in the other side of the world. Today, I have the distinct honor and pleasure to introduce Dr. Adrià Juanola. Dr. Juanola is a recognized researcher at the hospital clinic in Barcelona, affiliated with the Chronic Liver Diseases, Molecular Mechanisms, and Clinical Consequences Group, where he holds an R3 level accreditation. His work is deeply engaged with complications of decompensated liver disease, particularly cirrhosis, and centers on identifying prognostic biomarkers and therapeutic strategies. Dr. Juanola is an accomplished author with more than 100 published research works and over 1,600 citations to his name. Recent highlights include landmark randomized multicenter AlbuCAT trial, which demonstrated that short-term intravenous albumin administration improves serum sodium levels in hospitalized cirrhotic patients with dilutional hyponatremia. Is also known for work on novel biomarkers, including urinary L FABP, with the liver fatty acid binding protein, and NGAL. This is neutrophil gelatinase-associated lipocalin, which have significant prognostic value in ACLF and mortality prediction. In addition to his clinical trials and translational work, Dr. Juanola contributes to broader public health initiatives such as cirrhosis screening strategies across Europe. He co-authored a comprehensive review on the promises and pitfalls of population-level liver fibrosis and cirrhosis screening in high-risk populations. With that introduction, I would like to hand it over to Dr. Juanola. Over to you, Dr. Juanola. You can now share your screen and we'll start.
Hello, everyone, and thank you. Thank you for inviting me to speak today, and thank you all for joining today. And as Dr. Sarabati mentioned, my talk will be focused on the management of hyponatremia in patients with decompensated cirrhosis. I have nothing to disclose for this talk, and here is the outline for today. I will start with a brief summary on the pathogenesis of ascites that will help us to understand the mechanisms that underlie the development of ascites and, at the end, the development of hyponatremia in these patients. Then we will review some general aspects from hyponatremia, the causes, the clinical impact of the development of hyponatremia in patients with decompensated cirrhosis. And at the end, we will talk about the management of these patients, and I will give some notes and some results from the AlbuCAT trial, which is a trial we just finished a few months ago, and we just presented some results, some preliminary results in the last EASL meeting, and then the conclusion. So let's start from the beginning with the mechanism associated with ascites and the appearance of hyponatremia. Here you can see a pathology slide from a normal liver, and you all know that the blood flows from the portal territory to the central vein, and this is in a normal liver, but you know that there are some structural disturbances, mainly the development of regenerative nodules in patients who develop cirrhosis, and also there is an increment in the hepatic vascular tone, mainly produced by the local production of some vasoconstrictor molecules and some sinusoidal hypercontraction that induces an increase in the hepatic vascular resistance, which at the end promotes the development of an increased portal pressure and the development of portal hypertension. This is the first step in the pathogenesis of ascites, because we know that when there is an increase in the portal pressure, there are some local mechanisms, mainly the production of some vasodilators such as nitric oxide, but also carbon monoxide and endocannabinoids that they promote two effects. The first effect is an splanchnic vasodilation. This promotes a more subsequent increase in the portal pressure because there is more blood flow going to the splanchnic territory and then going through the portal vein, which will increase the pressure in the portal vein. But also this redistribution of the blood flow, what induces is a low effective arterial volume in the rest of the body, in the rest of the systemic circulation. Because of that, there are several counteracting mechanisms that try to restore these alterations. Mainly is the activation of the renin-angiotensin aldosterone system. Also, there is an activation of the sympathetic nervous system. And finally, there is also an increase on the vasopressin on the vasopressin levels. Also, at the early stages, there is an increase in the cardiac output that also tries to counteract this low effective arterial volume. This is data from some old studies more than 30 years ago that show that plasma renin activity, aldosterone, or norepinephrine were increased from healthy subjects to patients with compensated disease and patients with decompensated disease. You can see how the levels increase from these molecules through different stages of the disease. And also, more importantly, and related with the development of ascites, is the association between the levels of aldosterone, especially in patients with decompensated disease, that are the ones in the white dotted group, that as more aldosterone levels on the blood, there was a less capacity of urinary sodium excretion. So this sodium retention at the end with higher levels of aldosterone will promote the development of complications, mainly ascites. So as I mentioned, the sodium retention is associated with the renin-angiotensin-aldosterone system activation and will promote the development of ascites. The sympathetic nervous system activation will induce the development of peripheral vasoconstriction, and this is related with the risk or the development of hepatorenal syndrome. And finally, the release of vasopressin will promote the solute free water retention that at the end will cause the development of hyponatremia. And here is where I want to focus. Here is what we are going to talk today. Vasopressin is produced in the hypothalamus and is released in the pituitary gland. But the most important thing is that vasopressin is not easy to measure, it's not easy to calculate its levels in the blood, but we know that vasopressin is not produced alone. We know that vasopressin, arginine vasopressin, is synthesized together with neurophysin and copeptin. They are synthesized together, they come from the same gene, but just before vasopressin is released in the systemic circulation, there is a cleavage where copeptin is released, vasopressin is also released by itself, and we can measure copeptin. Copeptin has no role, or at least we don't know the role that copeptin has, but it is, to us, it is useful to measure copeptin levels as a surrogate for vasopressin. And in fact, there is a paper which was published years ago from Dr. Solá and Dr. Kerber that they show that plasma copeptin as a surrogate marker for vasopressin was associated with the prognosis of the disease. Those patients with decompensated disease had higher levels of copeptin, and not only this, copeptin levels correlate were positively correlated with plasma renin activity, with the aldosterone levels, with noradrenaline levels, and inversely correlated with serum sodium levels. And importantly, patients on this study that had hyponatremia had higher levels of copeptin, remember as a surrogate marker, than vasopressin, than patients who did not present hyponatremia. So copeptin was a useful marker to at least identify the activity of vasopressin and at least to identify or to correlate with patients with hyponatremia. And how vasopressin works. Here you have a cell from the renal collecting duct. Here you have the blood compartment, and here the urine compartment. Here is the B2 receptor, and when vasopressin binds to this receptor, there is an activation of adenyl cyclase, which at the end will turn into the expression of aquaporin 2, which is a channel that is expressed in the apical membrane and allows the reabsorption of free water, that this free water goes from the apical membrane, from the urine to the basolateral membrane, to the blood, and this solute free water retention, reabsorption, will make that the concentration in the blood of different solutes, such as sodium, will decrease its concentration, so it will induce an increase in the total volume, in the total blood volume, but it will induce a decrease in the concentration of serum sodium. It will induce a dilutional hyponatremia, which is characteristic of patients with decompensated cirrhosis and is the topic that we are discussing today. So now we have seen how these patients with decompensated develop hyponatremia. Now let's see some general notes about hyponatremia. Hyponatremia in patients with decompensated cirrhosis is defined by consensus as a serum sodium concentration under 130 milliequivalents per liter. However, I don't want to argue and to enter in any conflict, but I would say that also we should take into account that also patients with levels under 135 are also at risk at presenting some complications and also at risk for dying. If we compare these patients, I just want to mark this group of patients between 130 and 135. This is data from the study published by Dr. Kim in New England Journal of Medicine in 2008. And as you can see, this is the relative risk of death. This is one, which would be that the risk is equal, having the higher levels or the lower levels. But this group of patients is located above the one line. So these patients have higher relative risk of death compared to patients with higher levels of serum sodium. So I would not only focus on those patients under 130, but also those patients between 100 and 135. And later on, I will show you some more data that reinforce this concept or this idea that I would also to tell you today. So anyhow, 130, 135. It is not only important to identify patients with hyponatremia, but it is also important to identify which type of hyponatremia are our patients presenting. And I will just focus on the two main types, hypovolemic hyponatremia or hypervolemic or dilutional hyponatremia. These, I think, from my perspective, are the two most common types of hyponatremia that patients with decompensated cirrhosis develop. The first one is mainly associated with a contraction of the intravascular volume. This is produced by intense sodium loss. And this is commonly seen in patients who have overdiuresis. For instance, patients who we just started diuretic treatment for ascites, and this is a very intense diuretic treatment, and they have an overdiuresis and they finally present signs of dehydration. But also patients with diarrhea, which could have an origin on an infection, but also patients treated with lactulose, that is a common treatment prescribed in patients with decompensated cirrhosis. These patients also may have an intense sodium loss and they present dehydration, and these are the two common causes that may induce hypovolemic hyponatremia. And this is somehow easy to see in the emergency department or in the outpatient clinic, because the patient will present clear data of dehydration. Probably we will have registered that we just increased or started diuretic therapy, or we increased the dose of lactulose, or the patient will report that he or she is having some diarrhea the past days. And these patients commonly associate the presence of hepatic encephalopathy or some degree of dizziness. And the management in these patients is, I would say, easier than in patients with dilutional hyponatremia, than patients with hypervolemic hyponatremia. In patients with hypovolemic hyponatremia, we should treat the cause. We should stop diuretic treatment. We should treat the cause of the diarrhea or stop lactulose treatment. And maybe we can start giving some sodium, maybe with some saline, 0.9% sodium chloride would be enough to increase in a slow dose, would be enough to slowly increase the sodium levels, but just allowing the patient to get rehydrated, it would be enough to restore the sodium levels in this case. However, I want to focus on this second one, which will be the main type of hyponatremia. I will focus the rest of the talk. Hypervolemic hyponatremia, as I just explained in a few slides before, is produced by an increase in the solid-free water retention, and there is an expansion of the extracellular fluid volume. And because of this, all the patients that we diagnose with dilutional or hypervolemic hyponatremia must have ascites and or peripheral edema. We cannot diagnose a patient with hypervolemic hyponatremia without signs of ascites or without signs of edema. The presence of hepatic encephalopathy in these cases is variable, and we will see that these patients may present or may develop hepatic encephalopathy after developing hyponatremia. And the causes are diverse. We will review carefully, but just to tell you that because of the progression of the disease by itself can induce hyponatremia, also the infections, some fluids, mainly low oncotic fluids, may induce hypervolemic hyponatremia in patients with decompensated cirrhosis. And here the management is quite more difficult. You all know that. The management is based on fluid restriction, and we try to increase the solid-free water excretion, but as we will see, there are no specific treatments to do that, and currently our capacity to improve serum sodium levels is not as good as we would like. And hyponatremia is quite frequent. This is data from a classical study from Professor Angeli from Padova, where patients with cirrhosis, with decompensated cirrhosis, assess the frequency of hyponatremia. And if we put the threshold on 130, we see that around 1 out of 4, 1 out of 5 patients will have hyponatremia at some time. But if we put the threshold on 135, the frequency of hyponatremia increases up to 50% of patients. So hyponatremia, I would say, is quite common in patients with decompensated cirrhosis, depending on the threshold between 1 out of 5, up to 50% of patients will present hyponatremia. And we need to be aware that this is a significant complication, or at least is a red flag that we need to take seriously we need to check that this patient is going well, because if not, there will be several other complications that will make that this patient may die or may develop infections or hepatic encephalopathy, and the clinical course of these patients is much worse than patients with higher levels of serum sodium. And let's see which are the causes of dilutional hyponatremia. Let's see why these patients develop. And the first one is spontaneous, just because of the disease progression. As I explained you a few slides before, the mechanisms that lead to the development of ascites at the end will promote the development of hyponatremia because of the solid free water retention. Also, the fluid administration, especially, as I said, low oncotic fluids, 5% glucose, for instance, may induce hyponatremia, and we need to be very careful when we administer fluids in patients with decompensated cirrhosis, not only for cardiopulmonary overload, but also for the risk of developing hyponatremia. Bacterial infections also induce hyponatremia, and there are some drugs that we commonly use, or we, at least in Europe, I know that in States it was less frequent, but now you have terlipressin. Terlipressin commonly, or it is frequently seen that terlipressin may induce hyponatremia, especially in patients with variceal bleeding, not that common in patients with hepatorenal syndrome, who in fact, they commonly present some degree of hyponatremia when they have the diagnosis of hepatorenal syndrome, AKI. On the left graph, on the left diagram, you can see how patients from child A, child B, and child C from the study from Paolo Angeli, you can see that the frequency of levels of serum sodium above 135 decreases as the disease progresses, and the percentage of patients with levels under 130 increases from patients from child A to child B and child C. And this is just because of the progression of the disease and just the mechanism I showed you before about the vasopressin secretion, the vasopressin production, and the free water reabsorption. Also, there is data that patients who develop bacterial infections are at more risk of developing hyponatremia, and this is also a study performed 12 years ago, 13 years ago in our unit, and we saw that patients who present skin infections have higher frequency of hyponatremia compared to a control group of patients without infection. And this is because this was the diagram I showed you a few minutes before, but we also know that systemic inflammation, mainly driven by bacterial translocation and sterile inflammation, may also induce some vascular alterations, some hemodynamic disturbances that may infections, such as skin or soft tissue infections, but any infection can enhance these hemodynamic disturbances and can increase the levels or the counteracting mechanism, especially the vasopressin release, and may induce hyponatremia. And that's why also patients with decompensated cirrhosis who presents a bacterial infection may then develop hyponatremia. And why? Why is important hyponatremia, and why is important to diagnose these patients and to identify these patients properly? Because the development of hyponatremia is just, it will be associated probably with the development of hepatic encephalopathy. It will impair the quality of life of the patients, but mainly it has effects on prognosis, not only before liver transplantation, but also it has effects after liver transplantation. So we need to be careful with those patients who develop hyponatremia because their prognosis is severely impaired, and we need to act and we need to give them some treatment or try to identify the reason why this patient is developing hyponatremia and try to improve the sodium levels. Regarding the development of hepatic encephalopathy, here you have like a diagram about the pathophysiology of hepatic encephalopathy and the astrocyte swelling. It is mainly associated with the hyperammonemia and the glutamine synthesis. There is a water shift from the extracellular space that induce the astrocyte swelling and the astrocyte dysfunction, and at the end it will promote the development of hepatic encephalopathy. But there is also data that patients with hyponatremia, there is also a decrease in the extracellular osmolality, and this will also induce astrocyte swelling and at the end hepatic encephalopathy. And I want to mention this study that was performed many years ago, also here in the hospital clinic, where they performed magnetic resonance spectroscopy in patients with hepatic encephalopathy, and in patients with decompensated cirrhosis with different levels of serum sodium, and they tried to measure different osmolytes, brain osmolytes, and what they found, for instance, myoinositol or choline compounds, they found that levels of these compounds, these osmolytes that are present in the brain cells, their concentration in the brain cells was lower according to lower levels of serum sodium, and in the concentration of these osmolytes increased in parallel with the increase of serum sodium levels. Here you can see myoinositol and also choline compounds. This is showing that the patients with low levels of serum sodium have some degree of brain edema, and that's the reason why the concentration of these compounds is decreased. And not only this, we found, or it was shown, that the concentration of myoinositol, those subjects with low levels of myoinositol had higher probability of developing hepatic encephalopathy than those patients with higher levels of myoinositol. So the concentration of these molecules in the brain was associated with the development of hepatic encephalopathy, but mainly this was showing the grade of brain edema. But not only is important hyponatremia for the development of hepatic encephalopathy, it is also important for the quality of life of our patients, and we know that this is every time we are giving more relevance on the quality of life of the patients, of our patients, and the studies are now including more quality of life assessment in the studies. And this is a study published in JHEP in 2012, and they analyzed the quality of life through the SF-36, and what they found is that almost in all the aspects that SF-36 evaluates, the physical component, mental component, and the different domains, those subjects with low levels of serum sodium levels showed a worse show a worse quality of life compared with those patients with normal or serum sodium levels above 135. So hyponatremia is associated with hepatic encephalopathy and is associated with a worse quality of life. But also, and I think that this is probably the most relevant aspect, hyponatremia is associated with higher probability of mortality in patients with decompensated cirrhosis. This is data from Dr. Alondoño, and she showed that those patients with levels under 130 had a higher probability of dying during time of follow-up in patients in the waiting list for liver transplantation than patients with 135 or above levels of serum sodium. And I just want to show you that also patients that have serum sodium levels between 131 and 135 had also higher risk of mortality in the waiting list than patients with 135 or above. This data was just before MELD sodium was established as the score for prioritization for liver transplantation. This was used just with MELD score, not with MELD sodium score. Now we are using MELD sodium score just because of that, because we know that sodium has an impact on the mortality on the patients on the waiting list. But also, if hyponatremia is not only important just before liver transplantation, it is also important after liver transplantation. There are several studies. This study also showed that those subjects with higher levels of serum sodium had better probability or better post-transplantation outcomes than the patients with lower levels of serum sodium. And this is important because even the mechanisms that lead to the development of hyponatremia with the liver transplantation should at least disappear, or after a few weeks should disappear. We know that the levels previous liver transplantation has an impact after liver transplantation. So just be aware that try to optimize, try to improve the sodium levels of your patients just to improve the post-transplant outcome in these subjects. So clearly, hyponatremia is quite frequent, around 1 out of 5 or up to 50% of patients. It has several impacts in the development of complications, in the prognosis of patients. So how we treat these patients. And I just want to go back to the diagram that I showed you about the mechanisms that lead to the development of hyponatremia, and just start that importantly, stop diuretics and treat potential triggers. If the patient has a bacterial infection, treat the bacterial infection. If you just started some diuretics, just stop the diuretics and see how the levels of serum sodium evolve. If they improve, it's done. If they do not improve, we need to move forward and we need to decide what to do. And the first treatment that is proposed is the fluid restriction, the water restriction, around 1 or 1.5 liters per day. Also, the use of hypertonic solutions such as sodium chloride 3%. There are also baptans that may act on the vasopressin mechanism that we will review later on, and also albumin. There is data that has shown that albumin may improve serum sodium levels. So let's go one by one and see which is the evidence, or at least what they are used for. The first one is fluid restriction. As I mentioned, it is recommended 1 to 1.5 liters per day. Remember that this patient should also be treated with a low sodium diet. And the goal is to achieve a state of negative water balance. So if we are if our final balance, we are losing water, we're losing weight, the concentration at the end of serum sodium probably, or it is supposed it will increase, or at least it will maintain. So the idea is to achieve a state of negative water balance. So try to limit the fluid intake in these patients. However, just to avoid a very strictly fluid restriction, because it may induce some problems to the patients, and it is really difficult to follow a very strictly fluid restriction. So around 1 liter, it would be what is recommended for fluid restriction. Also, as I mentioned, sodium restriction should also be continued. And the studies, despite this is something that it is recommended, the studies have shown limited efficacy, mainly during the first 24-48 hours. And what is helpful is in preventing further decrease. So probably if we recommend fluid restriction, the levels of serum sodium probably they will not increase too much, but at least they will stop decreasing. And probably this is something important, because it is not the same to have a serum sodium on 130 than on 125. The second option is the use of hypertonic sodium chloride, 3%. These solutions, from my perspective, should be avoided, at least as a general treatment, because they may increase temporarily the levels of serum sodium. At the end, you are increasing the sodium retention, and they will increase the presence of ascites. They will increase, or they will promote the development of edema, also the pulmonary edema. So try to avoid, unless the patient has severe symptoms, of hyponatremia, and also because administering this type of solutions may lead to ODS, and this is a very severe neurological complication that we need to avoid, and we need to avoid that these patients we correct too fast the serum sodium concentration. As I mentioned, this is only limited to very severe symptomatic patients with hyponatremia, which is not frequent because these patients develop hyponatremia progressively, and there is some kind of balance, and there are no severe symptoms in patients displaying mild hyponatremia. If you have a patient with 113, 115, something like that, maybe these kind of solutions would be useful, especially if they are if they will be transplanted in the following days, just to increase the levels of serum sodium, and just the patient gets a higher serum sodium levels just before the liver transplant the liver transplant takes place. So from my perspective, you have this option. You can use hypertonic sodium chloride, but just use it in a very, very, very specific setting, and always use it under a strictly monitoring condition, maybe in ICU, and just evaluating the serum sodium levels every 8-12 hours, and in a rate of 15 to 30 mLs per hour. And importantly, do not increase more than 8 milliequivalents per liter per day of serum sodium in a patient with hyponatremia because of the risk of developing ODS. The following treatment, and that there was some that there are several studies that have evaluated are the baptans. As you know, baptans are an antagonist of B2 receptors of arginine vasopressin in the cells of the collecting ducts. And you know that vasopressin was the main mechanism for solid-free water reabsorption and for the promotion for hyponatremia. And if we block this union between vasopressin and the B2 receptor, any of these will take place, and there will be an increase on the solid free water excretion, and probably this patient should improve hyponatremia. And in fact, there is data that improves serum sodium concentration, and baptans were approved for patients with decompensated cirrhosis to treat dilutional hyponatremia or hypervolemic hyponatremia. Because of this data. This is data from two different studies, one study with tolvaptan and with one study with satabaptan. And as you can see, compared with placebo on the black line here on the right diagram, and here also on this line placebo, those patients who receive any type of baptan, satabaptan, tolvaptan, improved their sodium levels. So baptans improve sodium levels. This was under strict conditions in patients in randomized clinical trials. However, a later study between Padova and hospital clinics showed that the results in a real-life scenario of baptans are not where the results from the clinical trials were not reproduced in the real practice when we analyze the real practice pattern. So there is this discrepancy between real life and clinical trials, and importantly, there is a warning from the FDA about the potential that baptans may induce liver toxicity. This warning derives from studies not performed in patients with cirrhosis, performed in patients with polycystic kidney disease, which they receive treatment for longer time than patients with decompensated cirrhosis. And some of that patients develop some degree of liver injury, and because of that, and the potentially that baptans may induce liver toxicity, the FDA recommended not to use, or at least they recommend to avoid the use of baptans in patients with liver disease. And that's why baptans are not currently recommended in patients with hyponatremia and decompensated cirrhosis. And finally, let's move to the albumin. You all know that albumin is used for different aspects in decompensated cirrhosis after large volume paracentesis in patients with hepatorenal syndrome. There is some data that chronic administration of albumin may improve outcomes in patients with decompensated cirrhosis. And there were some evidence, or at least some data, that the use of albumin may improve sodium levels. And this has been hypothesized because it may increase the urinary free water clearance by expanding the intravascular volume. So as we expand the intravascular volume, the counteracting mechanisms that were activated, such as renin-angiotensin-aldosterone system, sympathetic nervous system, or vasopressin production, they are decreased, and probably the consequences, mainly the solid free water retention, they do not take place, and the sodium levels will improve. There is data from, this is one of the first studies that evaluate that. In fact, this is not a study, this is just a report of some patients. It was published in 1990 in GAT. And these are 3 patients. And as you can see here, you have the levels of serum sodium. And when patients start receiving albumin, 5% albumin or 20% albumin, the levels of serum sodium increased. Here you have, like, here the patient did not receive albumin and the level just decreases low a little bit, but then after a new dose of albumin, the levels start to increase again. Here the same, a patient decreasing the levels of serum sodium, but the patient here receives albumin and then the levels increase. Also here spironolactone was stopped, and here the same. These are 3 reports of 3 patients that they reported in GAT in 1990. But after this, we have the answer trial, where there is that you all probably are aware of this study. This study was published a few years ago in Lancet, and they evaluated the use of albumin routinely every 2 weeks in outpatients with decompensated cirrhosis to evaluate. The main outcome was survival, and they found that albumin may improve outcomes in these patients, with decompensated cirrhosis. But this is a post-hoc analysis that was published in American Journal of Gastroenterology, that they evaluated the almost 150 patients with sodium levels under 135 at baseline. So is that patients receiving albumin in the red line, they increased the levels of serum sodium, and this was maintained during all the follow-up. And also the cumulative incidence of correction of hyponatremia was higher in patients receiving albumin compared in patients receiving standard medical therapy, not receiving albumin. So albumin seems to have a role, seems to improve levels of serum sodium. There are also other studies that have evaluated this. There is also data from the entire trial, and there is a retrospective analysis from Dr. Bajaj, also in American Journal of Gastroenterology, that showed similar data. So based on this data, we decided to perform the AlbuCAT trial, which was title was Albumin for Management of Hypervolemic Hyponatremia in Patients with Decompensated Cirrhosis. This was a proof of concept study, small study, just to really evaluate if albumin administration had a role to improve serum sodium levels. And the primary objective was to evaluate the efficacy and safety of short-term albumin administration as a treatment for hypervolemic hyponatremia in patients with decompensated cirrhosis. The AlbuCAT trial is a phase 2 trial, multicenter, open control randomized clinical trial. It was performed in 4 Catalan centers in Hospital Clínic, Parc Taulí, Moisès Broggi, Hospital de Sant Pau. We included patients with decompensated cirrhosis and hypervolemic hyponatremia with a threshold of 133 milliequivalents per liter. And these are the exclusion criteria. We did not include patients with acute kidney injury greater than 1B, because these patients must receive albumin. Also patients with active infection unless they are treated for 48 hours, because of the potential that infections may induce hyponatremia. And if we treat the infection and the patient recovers from the infection, maybe per se the hyponatremia will, and the sodium levels will be restored. Also other structural cardiomyopathy or ACLF, severe hepatic alcoholic hepatitis, and also patients who were under treatment with diuretics, albumin, terlipressin, or somatostatin. They must stop at least within the 3 previous days. Okay, so these are the exclusion criteria, and this is the schedule of the trial. 26 patients per group, 52 in total. The control group was fluid restriction and sodium restriction, and the treatment group, the human albumin group, they received 1 gram of albumin per kilogram the first day and 40 grams daily during the following 9 days, or until hyponatremia resolution, that it was defined as an increase in serum sodium levels of more than 5 milliequivalents with a final value over 130, maintained for at least 2 determinations in 2 following days during the 10-day treatment period. This data was presented in the EASL meeting last year, and this is the flow chart. 104 patients were initially screened. Here you can see that the main cause of exclusion was that patients were under treatment with diuretics. They had AKI, and some patients had severe alcoholic hepatitis or ACLF. But at the end, 52 were randomized, 25 to receive standard medical therapy plus albumin, and 27 standard medical therapy, and were included in the final analysis. And here are the data. Just want you to show you that they are classical cohort of patients with decompensated cirrhosis, around 60 years old, mostly male. Alcohol liver disease was the most common. A MELD score, not MELD sodium score, MELD score around 17, 18. All of them had ascites because, as I mentioned, dilutional hyponatremia can only be diagnosed in patients with ascites, and levels of sodium around 127, 126.9, and 26.4. No difference were seen between variables between both groups. And regarding the primary endpoint, that is the only endpoint, the only outcome we have reported, you can see that the resolution rate was 12% in the albumin group against 4 patients, 15% in the standard medical therapy. This is the relative risk of 3.39 of recovering from hyponatremia in patients receiving albumin compared patients receiving standard medical therapy. And here are the levels, and you can see in red the patients receiving albumin, in blue patients from standard of care, and you can see that that since day 4 the patients increase over 130, and this is quite maintained the following days. And patients from standard of care, they did not reach or almost not reach neither 130, and there was not a significant increase in serum sodium levels. So we think that the administration of albumin may be associated with an increase in serum sodium and resolution of hyponatremia in patients with decompensated cirrhosis, and apparently albumin appears to be beneficial in the treatment of these patients. We have further analysis planned to be reported in the next scientific meetings, probably in the AASLD or in the following ones, regarding survival, other liver-related complications, adverse events, but this will be on the next meetings. This has not been yet published, so it will be on the next probably American meeting. And just to conclude, remember that hypervolemic hyponatremia is a serious complication that accounts in patients with decompensated cirrhosis, and it is associated with disease progression, and it is associated with poor outcomes in these patients. It reflects the severity of cirrhosis, but also some factors such as infections may contribute to its development. Management at initial involves discontinuing diuretics and addressing the precipitant factors, just evaluating if the patient has an infection or we just change their medication. Water restriction and albumin seem to be the most effective strategies. The use of baptans, we know that they may be efficacy, they may have some efficacy, but there is a warning, and in fact, in real practice, the studies are not quite positive as clinical trials. But the use of baptans or the hypertonic saline should be individualized and should be only reserved for selected cases, and just use it under strict clinical monitoring and only in experienced centers, because they may induce some some damage in the patients, mainly ODS, the use of hypertonic saline, but the baptans may induce liver injury, so be aware if you are using these treatment options. And that's all from my side. Thank you, everyone, for your attention. Thank you again for the invitation. It's been a pleasure. And if you have any question or any comment, I'd be pleased to try to answer. Thank you very much.
Dr. Juanola, thank you. That was an excellent talk. Um, I will start with one question and then I'll let the audience uh, think through some questions and they can put. I also wanted to thank the audience as well, like joining from all around the world on a Saturday morning here in New York. But I think they're all from different parts of the world. Thank you everyone for joining today. I'm a transplant hepatologist, and we come into this scenario many a time, like patients coming in with a high MEL because of driven by hyponatremia. We capture the MEL score. Now the dilemma is, what is the safe limit that we can bring this patient's sodium corrected, so as to get this patient through the liver transplant without any consequence of ODS. We have our anesthesiologist, Dr. David Costera, is also here. I think from around the world, I think there are different limits that people think about. I don't think there is any standardized protocol as to how much to correct before safely you can get this patient, because the time limit here, you're dealing with the correction, and at the same time you're also looking into, you're getting the organ and you want to get this patient transplanted. So that's my question. If you can answer that, thank you.
So you are asking about the impact of
Yeah,
increasing sodium levels, the impact on MELT, and the prioritization and the
yeah.
time on the wait list. Yeah, I got your point. And in fact, I was thinking about, because I know that, well, you just say there is audience from different parts of the world, and in every region there are different policies for allocation. For instance, this question was arised when terlipressin treatment was started many years ago, and the prioritization in patients with hepatorenal syndrome who started terlipressin. In our region, what we do in patients with hepatorenal syndrome is we kept the highest MEL sodium with the creatinine. And I was thinking that those patients who develop hyponatremia, maybe we should kept the highest MEL sodium with the lowest sodium value. This would be an idea, and this would be an option. If this would be an option to keep the prioritization in these patients. However, I think there is no data on this, but I'm not sure if even if you restore the sodium levels of the patient, probably the prognosis improves. So probably I would advocate for improving sodium levels, then giving a new MEL sodium value. And if the patient, his odds for being transplant decrease, then it is what it is. The patient will have a chance later on, but for sure the sodium levels have increased. His probability of survival is higher, and also the risk for complications after liver transplantation is lower. So for sure, I would treat patients with hyponatremia. I would improve sodium levels in patients with hyponatremia on the waiting list.
And what's the safe limit that you would like to correct? Like, let's say patient coming in with a sodium level of 113, 112, and you are trying to correct it now to get this patient through the transplant. What would be a safe limit? Like 127, 130? Like, what would be their limit before you accept an organ?
I probably would go over 130, but for sure, if you have a patient under 120, you should improve that levels of serum sodium, and the level you should get probably 130 will give better better options. But if the patient has to be transplant, do not wait until the patient recovers from the serum sodium, unless the serum sodium levels are quite low, such as 120 or under. If the patient should receive the organ, then go for the transplant, then the levels will improve.
Thank you. May I invite Dr. David Costera, who is a prominent anesthesiologist and in our institution, who is in the meeting today. Dr. Costera, would you like to share your experience in while you're getting this patient through the transplant? How do you choose to correct this patient sodium level and to what level?
Hi, good morning. Can you hear me?
Yes, we can hear you very well.
Yes, I'm in the car, so it might be a little noisy. So, our biggest concern in the operating room is to not allow the sodium to come up. It's actually the opposite of what you're trying to do, preoperatively. It is very easy, particularly in cases where there's significant blood loss and administration of blood products, acid-base disturbances with administration of sodium bicarb for the sodium to climb very quickly intraoperatively. You can very easily see 8 to 10 point increase during a big bleeding case. In cases where the patient is presenting with low sodiums in the 120, 125 range, we're now very conscientious about trying to keep the sodium down from the very beginning of the case, changing IV fluids, more use of free water to preemptively manage the increase in sodium. We did have one case of ODS. It was very devastating to see. Fortunately, that patient recovered. But a lot more emphasis on preventing the increase intra-op. And that's always been the biggest concern peri-op for us.
Thank you. Thank you for insights. We have several questions. Ilaha Jalilova. Ila, you want to ask these questions yourself?
Sure, no problem.
Yep.
Thank you so much again for this great presentation. And my first question would be, why do we need to continue low sodium diet with the fluid restriction when we are treating hyponatremia?
Because thank you for your question. Because the patient will then develop also ascites. Then you will have also the mechanism that also induces the reabsorption of free water is also associated with the reabsorption of sodium. So if you kept the patient has a normal sodium diet, the total sodium that the patient will intake, it will increase the sodium reabsorption, and then the sodium reabsorption, as it increases, it will increase the total volume of the patient. So the patient will have more ascites, more peripheral edema, more solid free water reabsorption at the end.
And your
Thank
second
you.
question?
Thank you.
Sorry, no. So eating with high sodium diet will not improve sodium levels.
Thank you. That explains a lot. And my second question is, you talked about the consequences of hyponatremia even post-liver transplant. And what are those exactly, if you don't mind to give a little?
Yeah, the anesthesia, Dr. Costero was just saying, no, that the risk of neurological complications because of a high increase during the surgery. This is just the perioperative. The main concern is that because that in the operating room maybe the patient needs different fluid balance. There are some that there might be a rapid increase in the sodium levels during the surgery, and this might induce ODS. So this would be very dramatic for the patient. But also there is many studies that have shown that patients with low levels of serum sodium previous liver transplantation have worse outcomes during the first year of follow-up in terms of survival than patients with higher levels of serum sodium. So that's because just associated with the prognosis of the patient after liver transplantation.
Thank you so much, Dr. Juanola.
Thank you.
Thank you, Elaha. Can I or may I ask Dr. George Magdi? Dr. Magdi, please introduce yourself as well. Would love to learn about you as well and get your questions in.
Thank you so much. I'm George Magdi. I'm a transplant hepatologist from Egypt. And my question is about I have always advocated for the standard use of IV albumin plus or minus large volume paracentesis in acutely decompensated cirrhosis, even if the standard indications like AKI or so are not present. Do you agree with this approach? to expand the use of IV albumin in inpatient acutely decompensated cirrhotic patients?
You are please unmute,
Sorry,
Dr. Juanola.
sorry. You mean irrespective if the patient undergoes a large volume paracentesis, just every patient with decompensated cirrhosis receiving albumin?
Yes, admitted patients with acutely decompensated cirrhosis and high MELD scores.
I think there is no data showing a benefit on this strategy. In fact, the entire trial did something like this. They gave albumin in patients with decompensated cirrhosis, and they found no beneficial effect. And I would only use albumin for their indications, only for patients with AKI 1B or higher, patients with hepatorenal syndrome, patients with large volume paracentesis. And if you have not other option, maybe patients with hyponatremia, but this is not, there is no indication in the guidelines, so just not use it. But I would not administrate albumin in all patients with decompensated cirrhosis.
Okay, thank you very much.
You're welcome.
Thank you very much. May I invite Dr. Mangesh Pragadala? Dr. Pragadala, please.
Yeah, that's a great lecture. And hyponatremia and liver disease is a very important area, especially given its high mortalities. But this is a question that I sometimes always think as a transplant hepatologist: is sodium just a number, or is it the physiology behind it? Because sometimes we get a patient who comes for an offer and the sodium is like 124, and the surgeons are putting pressure on us to correct the sodium for the transplant. So do you think, and given that huge volume shifts that happen after intraoperatively and perioperatively, do you think these patients should not be treated as a number, but more look at the physiology behind it and probably hold off from a transplant for 48 hours or so? Is there any impact on correcting the sodium and taking them for a transplant?
Okay, thank you for your question and for your comment. I think there is no data on improving the levels of sodium just before the surgery. So unless the patient have very, very, very low levels of serum sodium, under 120 or something like that, if the patient has to be transplanted, then go for the transplant, and just be aware that the patient had lower levels of serum sodium just before the transplant, and just give cautiously some fluids, and just keep in mind that the patient may, just to avoid rapid increase of serum sodium. But I would, just before liver transplantation, I would not do anything special you are not doing, because even liver transplantation is, I would say, like a common surgery that is performed in large centers, and it's performed daily. I think that we need to be cautious what we do during liver transplantation, and just to be focused on the standard procedures. And if the patient has a value between 120, 130, if he or she has to be transplanted, then go for the transplant, and just to be aware of the levels of sodium, but don't do anything special on that.
Thank you.
Thank you very much. May I invite Dr. Pranab Penniti? Dr. Penniti, please.
Hi, thanks for a great talk. I have two questions. One is that I know there's some data for the SGLT2 inhibitors in folks with refractory ascites. And my question is, have you had any experience with using this class of medications in people with hyponatremia? Just because, my assumption is there is a osmotic diuretic effect. And so there could be some increased, free water clearance as a result. And so I wonder if there'd be any kind of benefit in this medication in terms of people who have mild hyponatremia with ongoing volume overload symptoms.
Yeah, thank you for your comment. Yes, there is, at least there is more interest there is a growing interest on the use of SGL2 T2, but I think there is no data on the use on hyponatremia. We are not currently using for treating hyponatremia. I understand your point that it may increase the excretion of solute free water, mainly for the because of the glucose excretion. But I'm not sure there is data, especially in patients with decompensated cirrhosis. There is some data on patients with ascites or on refractory ascites, but for sure larger studies are needed, and not only for hyponatremia, but also for patients with ascites. So we do not have experience And I think that there is no enough evidence to use it for treating patients even with ascites or patients with hyponatremia. But thank you. That's an important point, and probably in the near future, we will see some studies.
Great, thank you. If I can ask a second question briefly, just a practical question, but oftentimes seems like we have these patients who are massively volume overloaded, whose sodium levels are in the excuse me, in the mid 120s or so. And my question is it always the right answer just to stop diuretics? Should these people have an adjustment to where you stop the aldactone perhaps, but you treat with an IV loop, for improved free water clearance, as opposed to just stopping and trying to give some albumin?
Yeah, thank you. That's an important point, and I'm not sure that I have the correct answer on that, but I would say that the volume status of each patient is different, so we need to carefully assess always. From my perspective, or from my experience, it is uncommon that the patient has unless he has some cardiac problems, or he or she has received just before albumin or a lot of fluids before, that they have high cardiopulmonary pressures. So generally, despite the patients have ascites, they have peripheral edema. Intravascularly, they have low pressure, so probably they would benefit from using albumin and from removing or stopping loop diuretics or spironolactone. But I understand your point, and I think that every patient is different, so we should carefully assess the volume status of the patient just before stopping diuretics and starting albumin, for instance. And in these patients that have high atrial pressure, have high cardiopulmonary pressures, elevated cardiopulmonary pressures, in these patients, I would not use albumin and I would kept on diuretics for sure. But probably these patients have a different pathophysiology than a pure patient with decompensated cirrhosis.
Thank you, Dr. Penny. May I ask you to introduce yourself so that the audience know?
Yeah, sure. I just finished fellowship and I'm practicing as a hepatologist here in Columbus, Ohio.
Thank you very much for joining today as well. May I now invite Dr. Sapna Reddy? Dr. Reddy, please.
I think, thank you for this talk, and I appreciate these meetings. But I think he asked the same question that I wanted to ask, because I'm in community practice and we're constantly faced with this dilemma. When do we refer to nephrologists? And we feel nephrologists do not follow as closely as we do. And what type of adjustments and that was my main question, practical question.
So when to refer these patients to nephrologist?
Yeah, and when do we take over also and aggressively manage? Are there any other diuretics that we can push, especially when they don't have peripheral edema and they have massive ascites?
Okay, regarding the first question, I think that there should be always an important communication, an intense communication with nephrologists, because as you know, patients with decompensated cirrhosis are prone to develop kidney complications, and especially those patients with data on organic kidney failure, such as data on proteinuria, hematuria, or patients with chronic kidney disease. They should always be evaluated by nephrologists, from my perspective. And regarding the second point about the use of diuretics, the diuretics that we have most evidence or largest evidence are spironolactone or plerrenone and loop diuretics. The use of other diuretics can be used, but there is no large data such as other types of diuretics. So I would recommend, and in fact the guidelines, they do not recommend them. They just mention spironolactone or furosemide in combination. Spironolactone as the first choice, so I would go for spironolactone. But in patients with hyponatremia, I would, unless they have elevated cardiopulmonary pressure, I would stop them, both spironolactone and furosemide.
I think that one of the question was not answered, Dr. Juanola, is from Dr. Reddy. I think she is asking about if a patient that has no peripheral edema and has a large ascites, how to choose diuretics in these patients? Are
Oh, well, the first diuretic to use is spironolactone and furosemide or other loop diuretic should be added after spironolactone, but the first diuretic to be used is always spironolactone, not loop diuretics, because I haven't shown it in. I don't have the slide, but if you think on the tubules on the kidney or from the glomerulus, the loop diuretics act just before or act before the spironolactone act. So if you use you give loop diuretics, there won't be reabsorption of sodium, but when they arrive on the ductal at the end of the nephron, the sodium will be reabsorbed because of the activation of angiotensin aldosterone system. But if you use aldosterone, you will block that reabsorption and probably the excretion of sodium will be better. There is an old study from 1983, I think, that they showed that the use of spironolactone was better than the use of furosemide in patients with ascites. So the diuretic of use of the first choice should be spironolactone, and if the patient is not responding properly, then add or increase the spironolactone and then add furosemide or other loop diuretic.
Thank you. As a follow-up to that question, may I ask Dr. Juanola, in my personal experience, many time, one question that we try to answer is correction of hyponatremia, another is prevention of hyponatremia with the diuretics. So many of these patients in the hospital, I do use albumin-assisted diuresis, like they get let's say IV 40 milligram of Lasix along with just before that we give IV albumin, and I have seen in my personal experience and not that significant hyponatremia with that approach. Is that something you also do, or is there any data to support it?
Well, we don't use albumin. In general terms, we don't use it except for the indications in the guidelines. I know that, in fact, there are some studies that the use of albumin is associated with increase in the urine volume, increase sodium excretion. So it may has a role and it may have some background, but there are no clinical trials who support this strategy. But I understand that there are some patients that may benefit, and sometimes we do something that is not completely aligned with the evidence, but we know that sometimes this type of strategies work. But in general, the recommendation is only to use the albumin according to the guidelines.
Thank you very much. Now may I invite Dr. Diana Cheong. Dr. Cheong, please.
Hi, Dr. Satapathy. Thank you so much, Dr. Juanola, for that comprehensive lecture. Dr. Satapathy, I think you just asked my question about albumin-assisted diuresis, so I thank you.
Yeah.
No problem. Thank you very much again for joining today. Now, may I invite Dr. Benedict Maliakel, and anyone else, if you want to ask questions, please raise your hands as well so I can go in order.
Hi, thank you very much. I have, as usual, many questions about this area. Some of them, So first thing is post-paracentesis circulatory syndrome. I have a patient I saw yesterday with a sodium of 120. This patient is getting 7 liters, 8 liters of ascites removed weekly without albumin. And I think that post-paracentesis circulatory syndrome probably does cause hyponatremia, and that is why, albumin with, one more reason for albumin use in large volume paracentesis. I wanted your comment on that. Uh, Second question is, we all know that patients admitted with hepatorenal syndrome and inpatient situation, there is secondary hypocortisolism, secondary adrenal insufficiency. And so maybe there are some patients who we use aldosterone inhibitors who develop hyponatremia, that may have mild or some borderline corticosteroid insufficiency. Is there any studies to that effect? I'll ask the other questions later.
Okay. Regarding your first question, I would encourage you to use if it is available to use albumin in this patient that you mentioned who is undergoing a weekly paracentesis, large volume
Yeah,
paracentesis.
I just saw the patient for the first time
Oh,
yesterday.
okay. It's fine, but I think that this patient, what he or she is not doing is just following a low sodium diet, because if he or she is developing 8 liters per week, this means that he or she is eating over 80 milliequivalents of sodium per day, which is what is recommended. But yes, for sure, this patient should undergo should receive albumin after large volume paracentesis, and we will see if sodium levels improve or not. Anyhow, regarding the second question about the
Aldosterone inhibitors.
adrenal insufficiency, the use of aldosterone, well, there were several reports and several data that there is some adrenal insufficiency in patients with decompensated cirrhosis. And there have been some prospective studies trying to counteract this mechanism without being positive, the main outcomes of these studies. And I think that this is, I'm not sure about the relevance of adrenal insufficiency in patients with hyponatremia and decompensated cirrhosis. I think that the other mechanisms are more important, and we can use and the use of diuretics is a common cause of hyponatremia, and also the progression of the disease. But mainly, I am not sure how adrenal insufficiency, if it's that frequent, that induces hyponatremia in these patients, and treating adrenal insufficiency will improve hyponatremia. So I'm not sure about this, and I'm not aware if there is enough data addressing this point.
Thank you. The other question is, in patients with hyponatremia, I use lactulose, oral lactulose or oral polyethylene glycol, just, Miralax, which we have. And that definitely helps improve hyponatremia because of, causing osmotic diarrhea. And I see that, happen in many ICUs because people get so much lactulose that their sodium goes up and up. So that could be used as a countermeasure in patients with hyponatremia, hypervolemic, to have some water go, and it's probably good for, patients with hepatic encephalopathy on top of that. And maybe there is some role of keeping the sodium up. The lactulose role may be more than just, bacterial change in the colon. There may be a role for stabilizing hyponatremia in lactulose use.
Thank you for this second question. I don't have experience on what you are mentioning about the improving. I've never realized, and I have never read about lactulose improving sodium levels. Sorry about that, but I'll check for the next patients I have in the ICU if they are under treatment with lactulose and they improve it.
Thank you so much, Dr. Maliakal. I see Dr.
Thank you.
Bob Giss in our audience, very patiently waiting. Dr. Giss, thank you for joining as well. And if you can share some experience and thoughts and some questions here. Bob Giss, I think, not sure where he is, but well, I mean, these are great questions actually, and the discussion was quite engaging.
Can I ask one last question?
Sure, Dr.
I
Maliakal.
mean, in a patient with chronic hyponatremia with ascites, do you have comments on the role of doing a TIPS, early TIPS, or something of that nature to solve both ascites and hyponatremia?
Okay, I think that hyponatremia is a factor that has been associated with the risk of developing hepatic encephalopathy after TIPS. There is some data on this. I would. It's difficult to me in a patient with that grade of severe disease to perform a TIPS, probably because these patients have a very small liver. They usually have sarcopenia, which is also a bad prognostic factor for placing TIPS. So patients with that grade of severe disease, I think they are out of the scope of a TIPS in patients with if you indicate the TIPS for refractory ascites. So I would not go on that way in these patients because of they are very fragile, and I would not advocate for the TIPS in this case.
Thanks.
You're welcome. Thank you.
Thank you very much.
Hi, Dr. Satapathy. This is Mubin Khan here from Chicago.
Yes,
I
Mubin.
apologize. One last question. It's a great lecture and a great talk. Piggybacking on Dr. Satapathy's thoughts about albumin and IV diuresis, I see some of the nephrologists practice giving salt taps along with it to counteract some of those negative effects. So, I mean, do you see it as is there any evidence behind it? I had some discussion back and forth the futility of salt taps in this situation, but do you see a role of this combo, IV fluids, diuretics, and salt taps in the hyponatremia management?
I would not recommend. Yeah, thank you for your question. I would not recommend using salt taps or anything like that in patients with decompensated cirrhosis because the ascites will increase massively, and you will have a patient with hyponatremia and with a tense ascites. So you will have two problems instead of one that was just hyponatremia. I would discourage completely the use of salt taps or solutions with high concentration of sodium because ascites will get worse for sure.
Yeah, I think this is a common practice
Thank you.
for many nephrologists, and we once we consult the nephrologist, and we come into this dilemma because they take over the care and they start prescribing salt taps, and which is we are completely against the use of the salt taps in these patients, and it always creates a conflict. I think it just needs more education here. These kind of lectures that we're doing right now, I think they need people needs to understand the pathophysiology behind it. Even I'm not demeaning or devaluing their insight, but certainly has to be evidence-based, and this is not evidence-based to use salt taps in these patients. And so I think the good idea to ask the nephrologist about, is it your judgment call or is it evidence-based, and let them, answer that question. I think we have a last question. Maybe this is Dr. Subham Sarma who's asking the role of rifaximin and LOLA in probably management of hyponatremia. The question is, do you have any insights into this?
No, we do not have data on this, and I haven't read about this. I know that the most common use of rifaximin is to prevent recurrent hepatic encephalopathy. I'm not sure if there is data on the use for rifaximin for hyponatremia. What we have seen is that the chronic use of rifaximin and simvastatin in the Liver Hope trial that was just published in JAMA was not associated with an improving on complications of decompensated cirrhosis and the prevention of ACLF. So not sure it has a role in preventing the development of hyponatremia or treating hyponatremia rifaximin.
Thank you. I think there are some studies looking into long-term effect of rifaximin, like meta-analysis has been published on a few studies where they have reported reduction of HRS. And I don't think there is any study, any relationship to hyponatremia, as you mentioned. Yeah, thank you very much on that. And Dr. Casey has been asking from Nepal. Sudhanshu Casey, what about slow IV infusion of diuretics and a slow albumin infusion? Maybe that'll be our last question.
Yeah, that's something. It is not on the guidelines, and I think this is something that is done sometimes. I would say in almost all the hospitals. I and this depends on the experience of every clinician, and I think this is out of the scope of the guidelines, and for sure there are patients that would benefit from this strategy, but in general terms, it is not recommended to combine both, because if you are using diuretics, then while you are trying to increase the volemia of the patient, or if you are trying to increase the volemia, why are you using diuretics? So if the patient is or hypervolemic or hypovolemic in terms of intravascularly. So the combination is difficult to justify, at least with the evidence, but I understand that there might be some cases that we all use this combination.
Juanola, thank you so much. Thank you for an excellent talk again. And also I would like to thank the audience who had joined from all around the world and for such an engaging discussion. And this is such an important topic that you covered today. I think personally I learned, and I think our audience would benefit. And with your permission, we'll get this lecture on the website so that those who have missed, they can go back and listen to the talk. And again, thank you very much for your time and live from Barcelona.
Thank you again for the invitation, and thank you all who joined and for the questions and the discussion. It's been a pleasure. Thank you very much.
Thank you.
Thank you. Bye bye. Bye bye, everyone.
Bye. Bye.